Hello, everyone, and welcome to our Zoom meeting. Today, we will have different topics, and here's a list of the topics, and presenters will start soon. So I'm going to just stop my screen sharing, and Dr. Razaz will start. Before that, I'd like to thank you all for joining, and I'd like to congratulate all those who match this year. So during the meeting, maybe some of the seniors who match will let us know if how they feel and share their experience. So without ado, please, Dr. Razaz, go ahead and you can start.
Yes, I will. Thank you. All right. Assalamu alaikum. My name is Razaz, and I will be talking to you about nutrition and weight. And firstly, again, congratulations to everyone who matched, and better luck, inshallah, next year to anybody who didn't. Okay. So, nutrition and weight is a really big topic, and it's really important one. And in the elderly, we're gonna walk through it uh, in a lot of points of it, and we will realize how a little bit complicated it is because at the end of the day, food is life, and it's a really huge part of our day, of our health. So yeah. So the objectives are going to be age-related changes in nutritional health, how to screen for and assess nutritional status, nutritional syndromes common in the older adults, nutritional interventions for undernutrition, legal and ethical issues related to nutrition. Sorry, I'm just going to try to hide the screen. Okay. Nutrition is an important element of health in the older population and affects the aging process. The prevalence of malnutrition increasing in this population and is associated with a decline in functional status, impaired muscle function, decreased bone mass, immune dysfunction, anemia, reduced cognitive function, poor wound healing, delayed recovery from surgery, higher hospital readmission rates, and many other comorbidities. It's not easy to navigate nutrition when we're talking about an older person. Is my screen moving?
No.
No? Okay, sorry, just okay. Okay. Older people often have reduced appetite and energy expenditure, which coupled with a decline in biological and physiological functions, such as reduced lean body mass, changes in cytokine and hormonal levels, and changes in fluid electrolyte regulation, delay gastric emptying, and diminished senses of smell and taste. In addition, pathologic changes of aging, such as chronic diseases and psychological illness, all play a role in the complex etiology of malnutrition in older people. So it's not about only about eating. It's about what happens inside of the body, and a lot of changes do happen inside our body the older that we get. And sadly, that's not something we can control, but we can help make it a little bit better. So, what is malnutrition? Malnutrition is defined as a state in which a deficiency, excess, or imbalance of energy, protein, and other nutrients causes adverse effects on the body, form, function, and clinical outcome. It is more common and increasing in the older population due to the all reasons that I listed in the first few slides. Okay, age-related nutritional changes. So what happens? First of all, the body composition changes, and I'm gonna tell you more about it in the next slides. Energy requirements, macronutrient needs, micronutrient requirements, and fluid needs. Changes in body composition with age. So what happens? What happens is normally the older that we get, the less bone mass we're going to have in our body. We're going to have decreased lean mass as well, water content. Instead of all of this, the body is going to compensate by increasing the total body fat, commonly increased intra-abdominal fat stores. Volume of distribution of many medications changes as a result of these shifts. Creatinine-based determination can overestimate renal clearance in older adults because, again, we're going to have decreased muscle mass. So having normal or low creatinine levels in an elderly doesn't mean that they have normal kidney functions. This is not the only lab test that we can rely on because it's going to overestimate the renal clearance. We cannot generalize well-standardized nutrient requirements of young or middle-aged adults to older adults. You can feed a baby what an adult ate. You can't feed an elderly what an adult eat. It really depends on the age. So each has their own feeding programs. So here's this video. I hope I can play it for you. Just a second. Yeah. So I'm just going to walk you through the digestive system, and I'm going to show you what happens the older that we get. So here we have the food in the mouth. We need to keep in mind that older people are going to have, most of the times, I think more than 50% of them do have problems in their teeth. So chewing for them is not easy. They're going to have, normally, it's normal to have decreased saliva production. So this is going to make chewing food harder for them. The muscles are going to get weaker. This is going to make chewing harder for them. So all of this is causing sort of stigma for older people because they really can't eat anything. So yeah, this is what happens in the mouth. And then when we move to the pharynx, it also becomes slow, and even in the esophagus, the peristalsis movement is also going to be slow, and the lower sphincter, the lower esophageal sphincter is going to be tighter. So all of this will make it harder for them to eat and digest food, and it could lead to aspiration. Sorry, okay. Biological changes of the digestive system. There are age-related changes in the GI tract. The difficulty is that with age, it can be difficult to exclude pathological factors such as diabetes, pancreatitis, liver disease, malignancy. We need to keep all of this in mind, and then we need to also navigate the problem that they're having. So if you have an older person that has dysphagia, it's not like someone who is in his 40 with dysphagia. You really gonna do another approach, and it's gonna be more broad, and it's gonna be more complicated. Since these factors will have potential adverse effects on the intestine, as well as the unpleasant side effect of poor medications used chronically. Okay, biological changes in the digestive system with aging. Pathological factors, age-related changes may overlap with conditions like I said, all of these diseases you really could struggle with distinguishing them both. The enteric nervous system, we're going to have neurodegeneration causing symptoms like dysphagia, reflux, and constipation, and even the impaired sense of smell, taste and smell. Caloric restriction may prevent neuronal loss. The healthier that you eat, the better it is for you. Motility. Aging reduces the esophageal and gastric motility, influencing colonic motility via cellular mechanisms, often leading to constipation. This is why most of the older people, they always struggle with constipation. Of course, there is the fact that they don't drink enough water, the fact that they take medications that could lead to constipation, but they also struggle with decreased motility. Gastric acid secretion, it declines with age. Prolonged use of proton pump inhibitors exacerbates low acid levels, so it's not a good thing to take chronically. Predisposing to bacterial overgrowth, malnutrition, and reduced micronutrient intake. Pancreas is going to change as well. We're going to have structural changes, but functional changes are often linked to either disease or drugs. The liver is going to change as well. We're going to have decreased size of the liver and blood flow with subtle microscopic changes, gene expression changes, inflammation, stress, fibrosis, and it could be diet sensitive. Small intestine, the declines in the villi, crypts, and mucosal surface are associated with age-related changes. Again, it just happens normally. Oh, it's stuck again. I'm sorry, I'm just gonna try. Okay. So again, this is a slide about the changes that happens in the elderly. We have at first deglutition, the poor dentition, like I said, the problem with their teeth, reduced muscular coordination and strength, the decreased salivary production, reduced peristaltic pressure. Okay, this is going to lead to, okay, just a second, I just want to fix something on the screen. Okay, I did. Sorry for that. Okay, this is going to lead to poorer tolerance of certain food textures, increased time to feed, increased rates of dysphagia and aspiration. And this is also causes a social stigma for older people because they would feel like they really can't eat what other people are eating. They're going to take a lot of time while they eat. All of this is really does really affect them emotionally. Digestion, like I said, we're going to have reduced gastric movement, and this is going to lead to increased GI symptoms with oral intake, reduction in digestion, and even absorption of the nutrients. Metabolism, we're going to have, this is really important, is that we're going to have reduced total energy expenditure, decreased adaptability to changes in calorie intake, and increased fat deposition. This is going to lead to either excessive weight loss or gain with changes in the oral intake, changes in body composition, which is known as sarcopenia or sarcopenic obesity. Appetite, they're going to have reduced drive to eat, reduced pleasure associated with eating. Like imagine having all of these struggles to eat. You're not going to be so happy or excited to be eating, right? So this is why they're going to actually have that. They're going to have reduced drive to eat. They're not going to find it enjoyable anymore. They will just find it like it's like taking a medication for them. It's like something really not nice to do. So this is going to lead to decreased overall intake. Social factors, isolation, dementia, food availability, poor functional status, the disability, all of this is going to lead to increased food insecurity, embarrassment during meals, leading to decreased overall intake. All right, these are the changes again. In the stomach, like I said, we're gonna have delayed emptying, nausea, reflux. The gastric acid secretion is either gonna remain constant or is gonna decline. It's gonna depend on whether they're taking medications or not, and maybe reduced by conditions like pernicious anemia, H. pylori infection, or entire reflux drugs. The small intestine, we're gonna have reduced motility, the gallbladder and the liver, we're going to have weakened contractions leading to fat malabsorption in the gallbladder. The liver mass, like I said, it's going to decrease with age. Colon, aging affects the nerve endings, leading to reduced motility, the constipation, or altering bowel habits, either diarrhea or constipation. Okay, metabolism changes with aging, energy regulation. The total energy expenditure decreases with age. Compensatory mechanisms for energy balance are blunted, leading to weight fluctuations. Metabolic adaptability, there's going to be reduced ability to adjust resting energy expenditure in response to caloric changes, enhances weight variability. Neurohormonal alterations, aging affects blood sugar and appetite regulations. Insulin insensitivity increases fat deposition and variable effectiveness of satiety hormones. And this is going to disrupt their hunger pathways. Eating patterns, changes in the GI hormones and physiological adaptations leads to persistent alterations in eating habits, causing under or over consumption of calories. Nutritional status in the elderly, these are just some um, definitions that I'm just going to introduce you to. Sarcopenia, like I said before, its aging leads to increased fat and reduced muscle mass and function. And this is the term sarcopenia. Primary sarcopenia is expected muscle loss and fat gain with aging. Secondary sarcopenia is accelerated by lifestyle, medications, chronic diseases, and poor diet. Friability correlates with muscle mass and performance, like hand grip strength, linked to higher disability and mortality risks. A health marker, body composition is a more accurate health indicator than weight or BMI in the elderly because we can't count on the BMI because they could have ascites, they could have a lot of conditions that could make their weight fluctuating. So body composition is more accurate and better for them. Diet quality, high vegetable intake and healthy eating index diets like rich in fruits, nuts, lean protein, and healthy fats reduces sarcopenia risks. Physical activity with adequate protein intake improves muscle mass and reduces morbidity, of course. Okay, physiological changes of the digestive system with aging. Um, we have a term called anorexia of aging, and this is decline in the appetite and food intake with age, resulting in up to 30% less daily intake by age 80. Energy intake decreases more than energy expenditure, leading to weight loss. Body weight and composition, weight and BMI increases until age 50 or to 60. Then it declines, increased body fat with reduced fat-free mass linked to hormonal and metabolic changes. Fat distribution shifts to intra-abdominal area, raising risks for insulin resistance and cardiovascular diseases. Weight loss mechanisms. Why do we lose weight? Why some elderly people lose weight is due to wasting, involuntary weight loss due to poor dietary intake. Maybe they're not eating enough or they're not eating well enough. Muscle and tissue loss caused by catabolism and chronic diseases like heart failure. Sarcopenia, decline in the skeletal muscle mass due to inactivity, hormonal changes, and neuronal degeneration. Okay. Physiological anorexia were also the hormonal changes in the cytokines and like IL-1, IL-6, TNF alpha, and hormonal shifts in leptin, high leptin, reduced ghrelin contribute to reduced hunger and prolonged satiety. Hunger satiety regulation, satiety hormones, elevated cholecystokinin and pancreatic polypeptide cause prolonged fullness. Leptin and insulin aging amplifies satiety signals, reducing appetite further. Okay, this is just a summary for what I just said. Anorexia of aging, we're gonna have the decreased exercise part, decreased energy expenditure, physiological changes in the hormones, cytokines, taste and smell, changes in the GI tract. Pathological changes with aging, medical, it could be due to drugs, psychological, or even social. Okay, what are the energy requirements for older adults? Reduced basal metabolic rate in older adults reflects loss of lean body mass, including the muscles. Basal metabolic rate is the principal determinant of the total energy expenditure. Estimation of energy needs based on body weight, 25 to 30 calorie per kg per day. Avoid overfeeding while still meeting basal requirements. Okay, here's the fun part. This is a really nice website. It is called My Plate. My Plate is sort of replacement of the food pyramid that we used to see a lot when we were little in every science book in every year, in every school year. So the idea of My Planet is it shows you how I'm gonna show you the you can just look at the picture. This is the plate. So it shows you what are you supposed to eat on a daily basis. And this is really helpful for the elderly because it really gives them a detailed idea of how their diet should be like. So here are the macronutrient needs. Food, protein, we need we don't need, the elderly people do need that, 0.8 gram per kg per day. Fat, 20 to 35% of the total energy intake per day. Of course, with reduced cholesterol, saturated fats, and trans fatty acids, we need to focus on the healthier fats like avocados, like nuts. Carbohydrates, 45 to 65% of total energy intake per day, with complex carbohydrate as the preferred fiber source. Fibers, 30 gram per day for men, 21 gram per day for women. So here's the website, My Plate. I tried it on an 88-year-old female. Uh, I made the height 170 centimeters, 90 kilos. She is going to be sedentary. She's not going to be moving because she's 88. It's really rare to find someone who is really that old and moving. So it's less than 30 minutes of day of moderate activity. And this is what the website gave me. To achieve a healthy weight, she needs to eat 1,600 calories a day. And it even gave me a detailed plan. You can see the plan. She needs to eat 1 cup of fruits, 2 cups of vegetables, 5 ounces of grains, etc. And it even shows you exactly what you should eat, how your activity level should be like. It is a really nice website. And this is where it's like a for her to track her progress. So it is nice. Again, I don't think anyone's gonna really use this, but it is really helpful. I think if you're taking care of someone old, if you're working in a nursing home, I think this is really nice. Okay, micronutrient needs. Average daily nutrient intake level estimated to meet the requirements of 97 to 98% of healthy individuals in a group. There are specific guidelines for older adults available online. Fluid needs for adults. Sorry. Okay. Normal aging is associated with decreased perception of thirst. So normally they don't feel thirst. So you really need to remind them to drink water to make sure that they're drinking enough water. Impaired response to serum osmolarity. Reduced ability to concentrate urine following fluid deprivation. Fluid needs of older adults can be met with 30 ml per kg per day of 1 ml per calorie ingested. A decline in fluid intake can also result from diseases, states that reduce mental or physical ability to recognize or express thirst, or that result in decreased access to water. Fluid needs may increase during episodes of fever, infection, as well as with diuretic or laxative therapy. The additional challenges that we might face is physical disabilities, cognitive impairments, and living alone. All of this is going to make them lose their perception of thirst. They could even forget if that the patient has dementia or Alzheimer's, or the patient can move, they're living alone. UTIs increase with age, so this also makes them feel like they don't want to drink water. All of these factors lead to dehydration. So dehydration is the most common fluid or electrolyte disturbance in older adults. Common signs of dehydration are decreased urine output, constipation, mucosal dryness, confusion. And none of these are sensitive or specific, of course. Okay, nutrition screening and assessment. How do I know if that old person is malnourished or not, and how is he doing? So we use different approaches. We have anthropometrics, the nutritional intake, the lab tests, drug-nutrient interactions, and multi-item tools for nutrition screening. So anthropometrics are measurements used for assessing national status of older adults. including the measuring of weight and height. The BMI. BMI should be not lower than 18.5, and it should be interpreted in the context of the individual's lifelong weight history. You should take detailed history of the patient and how his or her weight has been their entire life from their adulthood until their current age. However, some geriatric literature suggests a normal BMI for persons older than 65 from 24 until 29, because normally 24.9, I think, to 29 is overweight, but some literature suggests differently. Okay. Unintended weight loss of 10 pounds in the preceding 6 months is a useful indicator of morbidity, predictive of functional limitations, healthcare charges, need for hospitalization. Weight loss of 5% in 1 month or 10% in 6 months is significant. Okay, nutritional intake. Inadequate nutritional intake has been defined as average intake of food groups, nutrients, or energy 25 to 50% below a threshold level of the RDI. Poor intake is often an indication of illness. 5% to 18% of nursing home residents do not meet standards for adequate nutritional intake. Problems with obtaining food commonly contribute to inadequate nutritional intakes among older adults, and important to ascertain whether limitations in resources, transportation, functionality, that they may limit the access of food or the ability to prepare and consume food. Okay, lab tests. We have albumin. Albumin is a risk indicator for morbidity and mortality, and hypoalbuminemia lacks sensitivity and specificity as a nutritional indicator. It is associated with increased length of stay, complications, readmissions, and mortality in the hospitalized setting. It is influenced by factors like inflammation and infection. The prognostic value of low albumin, less than 3.5 gram, is used as a marker for injury, disease, or inflammation. Free albumin may be a better reflect short-term changes in protein status because it has a shorter half-life, but it has largely the same limitations as albumin. Cholesterol. Low cholesterol levels, less than 160 milligram, are often detected in individuals with serious underlying diseases such as malignancy. Acquired hypocholesterolemia, less than 160, is a non-specific feature of poor health status that is independent of nutrient or energy intake. It may reflect a pro-inflammatory condition. Community-dwelling older adults with both how low albumin and low cholesterol have higher rates of morbidity and mortality than those with either low albumin or low cholesterol alone. So if you have them, both of them are low, here is a great risk for morbidity and mortality. Drug-nutrient interactions. Medications can modify the nutrient needs and metabolism of older adults. Certain medications like the digoxin, phenytoin, even at the therapeutic levels, can cause anorexia in older adults. Many medications are known to interfere with taste and smell, and others can reduce the availability of specific nutrients. Some medications can reduce the intake by causing inattention, dysphagia, dysgeusia, or xerostomia, and medications that precipitate constipation can also reduce appetite. Here are a list of some drug-nutrient interactions. I'm not going to go through all of them, but I will just show you a little bit of it. If you have an alcoholic, you have to check all of these vitamins, make sure that they're not low, especially thiamine. Antacids, vitamin B12, folate, digoxin, zinc, diuretics, we've got zinc, magnesium, vitamin B6, metformin, vitamin B12, phenytoin, vitamin D, folate. SSRIs could lead to either weight gain or anorexia. Okay. This is the basic tenets of nutritional screening in elderly patients. Limitations to oral feeding, structural, cognitive accessibility, recent oral intake, current BMI, percentage of recent total body weight loss, lab evaluation, anthropometrics, comorbid health conditions, and medications. These are the signs of and symptoms of nutritional deficiency. I'm not going to go through all of them, but it's important to know them that if you have in the skin, the sign and symptom of nutritional deficiency is going to be dry, scaly skin, petechiae, photosensitivity, follicular hyperkeratosis, and it's going to depend on the nutrient deficiency. Hair is going to be thin, nails are going to be really weak, eyes, it could lead to night blindness, mouth, we're going to have bleeding gums, glossitis. In the neck, we could have thyroid enlargement or parotid gland enlargement, abdomen, diarrhea, and neurological is going to be anorexia, ataxia, tetany, dementia. Okay, what are the screening tools for malnutrition? We have a 5-step tool to identify malnourished adults for those at risk. Components, BMI, unexplained weight loss, and acute illness effect, drives malnutrition risk scores, low, medium, or high. Advantages, it's easy to use, 3 to 5 minutes, high predictive validity, hospital stay, mortality, discharge outcomes, applicable in hospitals and communities. The Nutrition Screening Initiative, 3 interdisciplinary tools to screen for nutrition risk and help evaluate the nutritional status of older adults. Determine checklist. 10 items self-report questionnaire identifies risk but does not diagnose malnutrition. Level 1 screen intended for use by healthcare professionals. It has additional assessment items regarding dietary habits, functional status, living environment, and weight changes, as well as measure of height and weight. Level 2 screen for use by more highly trained medical and nutritional professionals and suggested for use in the diagnosis of malnutrition. Mini nutritional assessment, it has 18 items, requires administration by a trained professional. It has short form, consists of 6 items, evaluates the risk of malnutrition among frail older adults and to identify those who might benefit from the early intervention. Available as an app for phones and tablets. Simplified nutrition assessment questionnaire. It can be answered by patients through the mail or while sitting in a waiting room. Sensitivity and specificity of 88% and 83.5 for identifying those at risk for weight loss. Risk factors for poor nutritional status. We have pathological and non-pathological causes of weight loss in older adults. Medical causes, chronic diseases, cardiac, respiratory, GI, malignancies, physical disabilities, alcoholism, poor dentition, and medications. Psychological causes, depression, dementia, Alzheimer's, anxiety, delirium, alcoholism. Social causes, poverty, isolation, inability to shop, prepare, or cook meals. Malnutrition and contributing factors in older adults. The prevalence, we have high rates of malnutrition in older adults. The dentition issues, 50% of individuals aged 65 to 74 use dentures, which may limit food type and quantity. Chewing problems are linked to poorer health and lower quality of life. Depression, it affects 2 to 10% of the elderly population, presenting commonly with loss of appetite and weight loss, accounts for 30 to 36% of weight loss in nursing homes and outpatient settings. Cognitive decline, dementia reduces energy intake, and late-stage Alzheimer's is often result in inability to self-feed, 50% to 50% within 8 years post-diagnosis. Olfactory changes in Alzheimer's may further decrease food intake. Social isolation. Those living alone eat less, but food intake increases up to 50% when eating with company. Nutrition syndromes of involuntary weight loss. Clinically important weight loss is a loss of 10 pounds or 4.5 kilograms or more than 5% of usual body weight over a period of 6 to 12 months. A BMI less than 17 is consistent with undernutrition. Excess loss of lean body mass is associated with poor wound healing, infections, pressure sores, depressed functional ability, and mortality. Involuntary weight loss is present in approximately 13% of older outpatients, 25 to 50% hospitalized older adults, and more than 50% of nursing home residents. Etiologies of involuntary weight loss, 50% of it is related to chronic diseases, 20% is neoplastic, 20% is idiopathic, including sarcopenia associated with aging, and 10% is psychological. Um, Evaluation should include for an involuntary weight loss, careful documentation of weight over time, detailed history including medical, dietary, and psychosocial elements, physical examination, focused additional testing based on the history, physical, and limited standard lab profile, institution of treatment of underlying cause, appropriate follow-up to assess response to the management. Nutritional therapy should include dietary education, removing dietary restrictions for chronic conditions, nutritional supplements given between meals, and a multivitamin or multimineral supplement. Obesity. Obesity is defined as a BMI more than 30, and it's associated with hypertension, diabetes mellitus, cardiovascular diseases, obstructive sleep apnea, and osteoarthritis. Adverse outcomes include impaired functional status, increased healthcare resource use, and increased mortality. Prevalence has increased in all age groups, both genders, and all racial and ethnic groups. The obesity paradox. The obesity paradox is a very, very interesting concept. It is applied to people with obesity as well as cardiovascular diseases. While obesity is a major risk factor for developing these diseases, patients with obesity have better outcomes when they experience MIs, strokes, or certain type of heart failure. A person without obesity is more likely to die from these experiences, and this was discovered by a doctor when that he realized that the patient that he had in his cardiovascular clinic with lower BMI had worse prognosis than those with higher BMIs. So the people with higher BMIs actually survived MI, survived cardiovascular diseases, and had better prognosis than those of lower BMIs. So it's not that bad after all when you have cardiovascular diseases and like you've already had the disease. So if you are obese, if you're overweight, actually it's good for your body. It's more protective than being underweight. Treatment of obesity goal is to achieve a more healthful weight to promote improved health, function, and quality of life. We need to keep in mind that we're dealing with people who are older than 70, 80, and they've been, most of the time, they've been obese for half of their life. So you really can't go to them and change their life in one day. They're not going to be convinced, and you shouldn't expect a lot. Even losing 5 to 10 kilos, starting by very little amount of goals is good because any weight that they're going to lose is going to be good for them. But at the same time, you don't want to make their life miserable because they are old and older people tend to have depression, they tend to have anxiety, they're alone. So if you tell them that, oh, you can't eat that and you should move more, you want to change their lives that they've been doing, a routine that they've been having for years. it's really going to affect their mental health. So you really need to have a delicate approach to them. You really need to not pressure them. So using a combination of prudential diet, behavior modification, physical activity is good for them. But again, like I said, you really shouldn't be hard on them. Role of bariatric is still unknown. It's not recommended and could lead to serious complications and increased mortality rates. This is also very interesting to read about because, again, they are old, they have weakened body, they probably have other comorbidities. So doing a bariatric surgery for them is not going to be the greatest option. For frail, obese older adults, emphasize preservation of strength and flexibility rather than weight reduction. Just make sure that they're moving, that they can get things done by themselves. Nutritional interventions, oral nutrition. Preventing undernutrition is much easier than treating it. Enhance food intake by catering to food preferences as much as possible, avoiding therapeutic diets unless their clinical value is certain. Even if you have a patient with diabetes, you shouldn't really restrict his diet because, again, this is not going to be good for them, for their mental health. They're going to make them feel miserable. They're going to make them have actually a worse prognosis because their disease is going to be like a limitation for them. So you should really be easy on them. Placing two or more patients together for meals can increase sociability and food intake. Preparing foods with appropriate consistency, attention to color, texture, temperature, and arrangement. Again, don't make it pale, don't make it dull. You should really make colorful food for them. Fruits, vegetables, they're colorful. Their food shouldn't be just like salt and pepper. Using herbs, spices, and hot foods helps to compensate for loss of the sense of taste and smell, and avoiding the excessive use of salt and sugar. Avoiding hard to open individual packages, giving adequate time for leisurely meals. Uh, Nutritional interventions, nutritional supplements often decrease food intake, but overall nutritional intake increases due to nutrient quality and supplement density. Contain macro and micronutrients available in liquid and bar forms, chosen based on patient preferences, chewing ability, or product cost. Current evidence does not support routine supplementation for homebound older people or well-nourished older patients in any settings. Use of micronutrient supplements is growing. Approximately 60% of older adults take prescribed dietary supplements. Many vitamin and mineral supplementations are commonly available in the supermarkets and drugstores and are generally safe, except for excessive intake for some vitamins such as vitamin A, D, and iron. There is poor to insufficient data that many nutritional supplements are beneficial. Imperative that the clinician obtain information about the patient's use of all supplements. Vitamin D deficiency. It occurs in more than 30% of individuals more than 70 years old. It's associated with impaired calcium absorption and reduced physical activity. We have insufficient evidence to screen for vitamin D deficiency in asymptomatic adults, may be appropriate for older patients at risk for deficiency, i.e. with weight loss, malnutrition. Current recommendations for older adults include daily intake of calcium, 1000 milligram, and vitamin D10 to prevent osteoporosis. Drug treatment for undernutrition syndromes. No reports demonstrating improvement in a long-term survival, and they may cause adverse effects, so it's not recommended. Some of the adverse effects are with metrazapine, caution with doses more than 15 due to hepatic and renal insufficiency. We have human growth hormone contraindicated in cancer states, hyperglycemia, and fluid retention. Steroids, there's no significant improvement in strength, function, or reduction in fractures. Legal and ethical issues. Food and fluid should always be offered to all patients. The decision to start or to discontinue artificial nutrition or hydration must be considered very carefully. Competent adults may choose to forego artificial feeding, just as they have the right to decline any invasive procedure. Um, advan- Advanced directives should be honored unless there is compelling evidence that the individual would have changed his or her mind in the current. In incompetent adults without advanced directives, the decision to start or to discontinue artificial feeding should be considered carefully with the surrogate. Take into account the risks and burdens of such an action, the risks and burdens of alternative actions, and the evidence to support likely benefits of the various actions. Current evidence does not support the use of feeding tubes in patients with end-stage cancer, dementia, or COPD. Palliative care, including emotional support, is extremely important at the end of life. In summary, nutritional concerns affect many aspects of health and diseases in older adults. Acceptable parameters of nutritional status, such as body weight, protein levels, should be maintained unless the patient's clinical condition demonstrates that this is not possible. There are many tools to help screen and assess for nutritional deficiencies. The decision to start or discontinue artificial nutrition or hydration must be considered very carefully. And these are the references that I used. And yeah, thank you so much for listening.
Go ahead, Dr. Yusra. Go ahead, Dr. Yusra, if you have question or comment.
Assalamu alaikum. Can you hear me?
Yes. Mhm.
Okay, right. Thank you so much, Dr. Razaz. It was a very rich presentation and full of many informative information. I just have two questions. The first one, you said that in older people, we should not depend on the BMI. We should depend on the body composition. What do you mean by that and how to calculate it? This is the first question. The second question is to Dr. Nader. I heard about something called gut microbiomes. I want to know, are you using it in the older people or not?
I will let Dr. Razaz go first and I'll
All
answer.
right. Thank you. Thank you, Dr. Yusra, for attending, and I really appreciate it. Using BMI is not the best option because, like I said, in some diseases we could have fluid retention, and could give us a false reduction of their BMI. So what we could use, the body composition are like the machines that you can do a very detailed body screening, like fat percentages, muscle percentages, water percentage, bone percentage, all of this you can get it, and this is gonna be really good for assessing their nutritional health. And there is also another approach where they measure their, the waist circumference and the calf circumference. There is this another approach. I hope this was helpful, Dr. Yusra.
Thank you, Dr. Razaz, and great
You're
presentation. Regarding Dr. Yusra, microbiome and biota in the gut, this is a new area and it's under investigation. Still, we are learning more and more every day. So we will talk about it. It's a big topic, but thank you so much. Any other questions, or we can move on to the next item in the agenda? Dr. Nadine, are you ready? Or
Yes, yes, I'll be sharing my screen now.
thank you.
I'm sorry, I had a technical problem. Have I missed something?
Sorry.
Is everything fine? Shall I start?
Yes.
Okay, so hello everyone. I'm Dr. Nadine Alamat. Today I'll be talking about a very crucial and a very important component of any research paper and any research project, which is the introduction. So the importance of this part of a research that is a well-crafted introduction, it's actually what sets the bar and what sets the stage for your study and what captures the audience attention. So today I'll walk you through the main components of any introduction of any research paper and how to make it effective and concise. The slides that is actually present and that you can find it on the website. So I'll start by giving you steps how to write a research paper introduction. So first step that you need to keep in mind is how to get your readers' attention. Key questions to keep in mind first before writing any research introduction, that's who is your audience or who's your targeted audience. So to write the introduction effectively, you need to know who they are and consider who is likely to be reading this paper and the extent of their knowledge of the topic. Then you need to begin your introduction with a sentence or two that will capture their interests. Also, you should keep in mind a key question, which is what will your paper talk about? What is the gap in the knowledge that you're going to be addressing? So that's your what that you should keep in mind. And also, you should keep in mind that what will grab your audience interest in this topic. So, for instance, you might begin with an interesting quote or an example of a situation that illustrates your argument. Or you could start simply by stating a fact that most people aren't aware of, which may be better approach in scientific field. Whichever method you use, just keep in mind and remember that academic writing, you should keep your phrasing formal and do not sensationalize it. This is the first step, is identifying your audience and what's the gap in knowledge that you're going to be addressing in your study. Step 2, explain why your topic matters. Key question to keep in mind in this step is why should reader care about your topic? And just as you'd like to understand where a new acquaintance is coming from, as you get to know them, your readers want to understand the background of your research. Once you've got their attention, explain why they should care. So first you identified the area or the missing gap in knowledge. And then you should tell the audience or the person who's reading that why is it important to fill in that gap and how important your topic is and your research paper is and how it's going to affect the field of knowledge and the research in the upcoming future in this field. What do readers need to know about or need to understand from your research? And what have other researchers said about this topic? What is the field's overview of this topic? All of these questions have to be addressed in your introduction. You can give a background for your research by discussing previous research on this topic. While this part should be shorter than a literature review, it can explore some of the same kinds of connections and themes. Just make sure that sources you cite relate to the arguments you're making or the problem you want to solve. The information you provide here should lay a factual foundation for your research. Step 3. You should lay out your argument and plan. After showing your reader the existing knowledge on this topic, you can turn to how this paper and how you're gonna contribute to that knowledge, to the new knowledge. Tying your research to a previous research is the most important aspect in this step. Explain why knowledge is missing from the existing research and how you're planning to uncover that knowledge. This is the most common place for thesis statement. And the purpose and main idea of this paper through it could be also appear at the end of step 4. So in this step, basically, you're going to be laying out your argument and your plan. And key questions to address is how does your research relate to the studies that you described previously, as I mentioned in step 2? What questions are you aiming to answer in your study, and what problem that you're looking to solve? What methods that you'll be using to answer that questions or to solve the problem? After that, you can move to step 4, which is define your direction. Beside introducing your readers to the topic and your related findings or arguments, you're introducing them to a research process and the paper itself. This means that you need to help them understand how this paper is organized and where it's going. Add a sentence or a few sentences, describe the sections of the paper in order, or the main ideas that you'll be covering in your study or in this paper. While longer papers typically need to include this step, shorter one, if you're writing an essay, you can skip this part. In these cases, the thesis statement outlines the paper structure. Key question to keep in mind while you're defining your direction and this step, which is step 4, what goal will each section of your paper accomplish, and what should readers take away from your paper? Now, we're going to talk about tips for writing a research paper introduction. So, as you go through the steps above, keep in mind that principle of quality academic writing, specifically understanding how to organize and summarize, will empower you to complete each step with excellence. So, key tips to write any strong introduction for your paper. First, to keep it smooth. A good flow helps readers to follow your logic. So there's a great example that is written here. Like when you first meet someone, you don't go ahead and dig into a deep conversations right on. First, you get to know their name, their hobbies. You get to know basic informations, and then you can go on and talk about more deep conversations. That's exactly how you're gonna go ahead with your introduction. So a flow of information. First, you get in the flow of information, as I've mentioned, from step 1 to step 4. And then digging deep into while going into your paper. That's how you're going to keep your readers engaged. And that's what makes it smooth and very clear for the readers. So to make your introduction flow, start with an outline. The outline functions like a skeleton. It provides a structure for the details that make up the introduction, like a muscles or other tissue. It helps you to make sure that you don't miss any important element. Then you flesh out the details, use the transition words and phrases between them to show how they really relate to each other. And another key tip while keeping in mind while you're writing is to keep it brief. Of course, like how long should a research paper introduction be? This question actually, it depends on the overall length of your paper. But the introduction is typically one of the shortest sections. For example, in a short paper, like an essay, you can complete each of the steps above in just a sentence of two. But in a longer one, you can each step might take a couple of paragraphs. But in a sense, the intro is a summary of the rest of the paper, and summarizing, it's all about prioritizing. As the business guru Karen Martin says, when everything is a priority, nothing is a priority. This means Martin was basically was talking about deciding which tasks are more urgent in a business. But the same principle actually goes about summarizing. You must decide which ideas are more fundamental and leave the rest out. Think, and this is the example I've mentioned before. Like when you meet someone first, you don't give an exhaustive list of all your traits. First, you go on with the basics, and then you move on as you go on with a deep and more detailed information. Another key tip is to write the introduction last and do it last. Since the introduction of the research paper is basically a summary, you might find it helpful to write it last. After you finish the rest of your paper, if you actually go ahead and write it first, there is a good chance that you will have to change some of these main points later. This can happen because the other sections of your paper, which your intro is based on, may evolve while you're writing in them. And of course, you should always go back and take a second or even a third look at every section of your research paper to check for errors and other necessary changes. But if you write the intro last, the editing is likely to take much less time. So you're actually going to save time, and the writing will be more clear, and it will be more concise. And lastly, we're going to talk about we're going to mention the tools to writing a research paper introduction. Now that we've actually introduced you to the basics of writing of a research paper introduction, we'd like to introduce you to a couple of steps that's going to help you to write this introduction and upgrade your writing skills. Here are a couple of methods that you can go ahead and use. Cite source using a citation generator. Avoid plagiarism using plagiarism checker. Reword the statements from previous research but still cite them using a paraphraser. And write spectacular and concise thesis statement or even your whole introduction section using a summarizer. And yeah, that's my introduction. That's my presentation about how to write an introduction for a research paper. I hope everything was clear. And if anyone has a question.
Thank you so much, Dr. Nadine. This is great. So after you have the idea about your research and you write the steps and you collect information or the data and you write your paper, the last part will be how to do the introduction. So as Dr. Nadine mentioned, there are steps to do that, and we want you to know how to, and there are some tools to help you as well. Thank you so much, Dr. Nadine. If no more questions, we can move on to the next agenda in the item agenda in the list. Okay, Dr. Rayan Mohammed, go ahead.
Okay, thank you very much for this presentation. I want to ask if I have an research about virtual, for example, as we do it here, virtual learning during the war in Sudan. And we have my introduction should focus on the war in Sudan or in the virtual learning as the main aspect of my introduction.
So as Dr. Nadine mentioned, it depends on different factors. One of the top factor or key factor is your audience. So what are you trying to reach? Who is your reader or who are your readers? So some journals focus on certain areas. For example, some educational journals will accept your papers to further their agenda or their goals. So if you are approaching these, then your introduction or your main goal is to focus on the tele research or tele education or tele health, for example. So if your target is the readers who are interested in education, medical education, and how to overcome any troubles or problems or struggling in this area, then your focus will be on the tele part. If, however, you are focusing on sending your paper to political journals or journals that focus on news or something, what's going on, then your focus or your key area will be on the war in Sudan or any other places, displacement and so on. If that makes sense. Thank you.
Yes, okay, thank you. Then before I start writing, I should determine which journal I'm sending to it.
That would be very helpful for you because sometimes you may, in your writing, you may highlight things that the journal might be interested in. And at the same time, you follow the footsteps of other published papers in the same journal. So if you are going in the same direction, it will be easier for reviewers to accept your paper instead of focusing on areas that might not be of interest to the journal. And we have some rejections in the past because the journal focus on certain areas or goals. And if the paper we are writing is, let's say, overgeneralized or broad, that will not help them or meet their criteria. So it will be automatic rejection and it will be faster for them. They say, oh, you are not meeting our goals or your topic is very generalized and so on. So it might be a good idea to look at a couple of journals that you might want to target. Thank you. Isra, go ahead. You are muted, Dr. Yusra. Dr. Yusra, if you have questions or comments, you are muted.
Thank you. Sorry, I have a problem during writing my introduction that while I'm writing the informations, like if I'm writing about, let's say, neglected tropical disease, if I want to define the neglected tropical disease, shall I go to specific researches that has defined the original researches that have defined neglected tropical disease? Or, for example, if I went through a recent paper that has got this definition from an older research, can I take the definition from the recent paper, or should I go to the original one that defined the neglected tropical disease? Sorry, I think it is too complex, my question, but I hope you get it.
So there is no problem of using two different ways of identifying or defining a problem or term or area of interest as your area, for example. So it depends on what exactly you want to show in your paper and to focus on. Some may suggest using both definitions. So you start with the earlier definition and what happened to the new definition. Why did they come up with the new definition? Is it to focus or to highlight or to direct the attention to certain area? If that's the case, you can say the first definition by so and so, and then second definition lately highlight this area, and then you can go by that. The other way is to pick and choose depending on what journal, again, you want to approach. If there are journals that focus on historical and basic science and basic information, then you go by the original source. If you are approaching journals that are newer, then maybe you can focus on the new definition. I hope that will help. Thank you.
Yes, but do the journals define this in their website that they want the basic researches?
But usually I do, I will go and look at their articles. So you search about different topics in the same journal and look at how other authors wrote their articles in the same area or in different areas. And by doing so, you will find how other authors used definitions for their topics. And depending on that, you can choose which method you want to use. So it's just a matter of learning how the journal will accept and publish their papers in the past. Thank you so much.
Thank you, Dr. Nati.
If no more questions, we can move on to the third topic. Dr. Mohammed, are you ready?
Yes, I am.
The floor is yours when you're ready.
Okay. So this is going to be somewhat of a practical demonstration. It's not going to be a presentation because the topic is a rather simple, practical topic on how to create Excel graphs. So it should be rather brief. Let me just share my screen. Okay. So this is not Excel, but it's a WPS, but it's virtually identical. So our task today is to learn how to create graphs using Excel. You can create graphs rather easily using Excel, although when you're actually conducting statistical analysis, there are more mainstream programs like SPSS or R that are often simpler than Excel when it comes to data analysis. But for just the purpose of creating charts, Excel will work quite well. So to start, let's define some elements. This is an Excel sheet. Each cell is called a cell. Horizontally are rows, vertically are columns. This is a range. A selection of any more than two cells is called a range. By the way, I apologize in advance. I have a cold, so my voice is a little. So, anyways, so this is an Excel sheet. Cells make up an Excel sheet. A group of sheets is called the workbook. So when we are creating charts, we often have data that is already compiled. So for example, here we have, let's take a example of a number of matched students from different universities. And we already know how many students each university has. So it's not simply data. If you just have data, you have to summarize it. And for example, if you have like a survey or a questionnaire and you ask what university and then you ask about the match status, you have raw data that you have to compile first before you get to the step of making charts. So once you compile your data and you have your data already summarized into categories and numbers, for example, now you're ready to create a chart. The simplest way to do this is to simply highlight your data and press insert. Sorry, the zoom here. And then you simply place chart. In Excel, you actually get something called a recommended chart. Well, they will show you the type of chart they recommend. So these are the type of charts. There are a lot of type of charts, and in Excel there's even more. But generally speaking, you rarely need to use any more than the first four types, which are the column, the line, the bar, the pie chart, and the bar. Using each one, whatever one, really depends on the type of data you have. Generally speaking, when you have categories with numbers, a column chart is usually ideal for this because it allows you to compare your data much easier between groups. So you can clearly see here that Harvard has more medical students compared to Yale compared to Princeton, and Princeton has more compared to Yale. This would be your chart. Now, once you created your chart, there's a lot of things you can do to modify your chart from designing and formatting viewpoints. First off, there's elements to the chart where you have the chart title, the axis, the vertical axis, and the horizontal axis. You can label your axis, you can label your chart element, and even the color, the distance, the various elements like the line, all this stuff are very uh, easy to edit, and you can explore them real easily. For example, right now, this is the chart title. You can delete it. You can uh, undo this and create it again. If you want the chart title to be the number of matched students, in Excel, there's a better way of doing this. You basically click the text, then you go to function, then you write equal, and then you highlight this triangle. Now, in the future, if this changes, the chart title will also change. And this is very useful because you don't need to manually update your chart title every time. In this program, this function sadly does not exist. I cannot press on here, but basically, I can just copy my chart title and put it here. Okay. So again, now we have different elements that allow us to format this. We can access it here via this switch toolbar, or we can access some elements of drawing tools or chart tools. In Excel would be chart design, and you can simply adjust every variable, every field you want. Like for example, if you want to change the color of the bar, you can easily select any color you want, depending on the theme, depending on what you want. You can get a gradient fill, no fill, picture, texture, anything you want. You can modify the distance between the charts. You can modify the font. You can modify almost anything. It's important to note that if you just press on the bar, the setting would be generalized to all the bars. So every single one of them change color. But if you double press, only the one you selected would be highlighted, and then you can change this one specifically while the rest will not be changed. This can be very helpful in if you want to personalize your charts and if you have something specific that you want to highlight. Okay, so let's just go through some elements that are really important. Like when you add a chart element, there's something called an axis title. This allows us to add either a horizontal or vertical title. If you want, for example, here to be universities, you can just add universities here. And you can write universities here. The same for the horizontal axis. You can also edit the number increments, the number lines. You can edit how high they go, how low they go. All these elements are very easily editable. You can just click on them and just follow the options. And the best way to learn stuff like this is usually through actual experimentation or working on projects, just like learning how to program. There's a decent uh, shortcut that can create charts almost instantaneously. If you press on any number in Excel, it will automatically. This works better with smaller tables like this. If you have a really big table, sometimes Excel will form weird charts. But if you press Alt and F1, a chart will automatically be formed without it. You don't have to go the insert and everything. This shortcut works in Excel. It also works in Google Sheets, as you will see shortly. Now, as I mentioned before, there are several types of charts. Selecting the specific chart usually depends on the type of data you have. So, for example, this type of data that we see in front of us here. Okay. A column chart would be ideal because we're comparing a limited number of options that are numerical. But if we, for example, see here, let's take this an example. Here we have a lot of uh, points. We have a lot of points, like the year, a lot of years. If we create a column chart, it will look cramped. So, for example, if you highlight this and press Alt and F1, what will happen in there are several problems with this chart, but let's look at the first problem. It is rather cramped. Okay, so all the data points are close together. So if we go and change the chart type into a bar type, it will actually usually look better. All right. Because it will allow us to display the date better. Now here, the chart was not created correctly because it did not recognize the years as years. It recognized them as number values. Okay, so it did not automatically recognize these numbers as years, but they were recognized as numbers. That's why if you see here, it shows us two bars. One of them is the year, the other one is the cases, and the cases because the number 12 is small compared to the number 2000. That's why you can see it's a very small 12 and number 2000. To fix this, either format your years properly. So, for example, write uh, year 2000 in every single one, or you format the bar to show a date, so specifically the first of each year or period, or you can format it, and after you've done the title, you can modify the title. The You can modify the entire by looking at the data, going to the text tools, sorry, the chart tools. Okay. Settings, select data. And then again here you can see there's series 1 and series 2 because the Excel considers both of these columns as data. So we don't want it to consider the year as a series, so we can unhighlight series 1, and then in the category we can edit the category, and then we can take this as a category. Okay. Okay. So what you see now, we have one series, which is the number of patients, and then we have the year, each specific year, as a separate entry. Even this, it's not very clear because we have a lot of categories. So something like a line chart may actually be even better for representing this data. So if you want to go somewhere like change the chart type, again, press select your chart and then go to change chart type, and let's select the line chart, for example. You see here, this is a much better representation of the data because it shows us the changing levels and with the changing year. So it's very important when choosing a specific chart, you have to choose a chart that goes well with the type of data you want to represent. Okay? You can further modify this in so many ways. You can make it display the number. You can make it display points here in the specific point. Have a point of a line that represents the trajectory of the data. There's so many ways you can modify your charts, and with trial and error, you can discover this really easily. Here you see an example of a data that be very well represented using something like a pie chart, because you have two categories that complement each other. So it's either male or female when you're talking about the sex of the patient, and you can very easily represent them using a bar chart, for example, a column chart. But it would be much better to present this type of data using something like a pie chart. As you can see here, it very intuitively shows us that there's less males than females in this population, and it very intuitively shows us that the ratio is something like 60%. So in reality, 67%. Again, we can experiment with this. We can change the colors. We can change the types. We can have some quick presets here that displays the value inside the pie charts. And you can do this, and you can also, if you have a specific style that you like, you can save it as a template and then apply to all other projects you have or any similar project. Now, one last point is it's also important when you have numbers, you have to decide how you want to represent those numbers. For example, in this table, you can see surgical infections divided by hospitals. As you can see, if you just look at the absolute numbers, you see that Hospital C has much less infections compared to the other hospitals. But if we actually compare the total number of patients, Hospital C does not see a lot of patients. So it's important to, for example, if you present this data as a chart, what will happen? It will be highly skewed. The data representation will not be fair. So for example, let's take here and then plus alt. So what we have here is the number of patients. You can actually, let's, for practice sake, add an axis. Let's add a vertical axis and call it number of patients, for example. Or number of infections. And then here we have the categories. You can change this into the different hospital names by doing the same thing we did before. So you do select data, and then you go to categories, and then you highlight the categories. Okay. Now we have hospital A, hospital B, hospital C. So what I did there, I pressed on the, I clicked on the axis, and then I modify the select data, and then I modified the category to reflect the hospitals. It's also interesting when you press on the chart, it actually highlights the area. So as you can see here are the wound catheter and IV line are the three bars, and then you have the data in blue, and then you have the categories in purple. So it actually shows you everything. If I actually managed to include the surgical infection in Excel, for example, if I made this type of equal to this cell, the surgical infection, it would also be highlighted. So that when you press on the chart, it actually highlights all the areas that are involved in the creation of the chart. Okay. So what we see here in this chart is Hospital C has way less infections compared to Hospital A, Hospital B, or Hospital D. If you actually go and press modify the layout into one that actually includes numbers, like this, for example, you can see the total number of patients. Of course, we can just add it as an element, by the way. So we can just add, like here, as an add chart element, and we can data labels, and then we can say outside end. So here, outside end, because we selected this bar, every single one was selected. If we did not select any bar, then we simply add chart element, and we add the data label. We could also do the same for the entire chart. But this view underemphasized Hospital C because it gave us total numbers. So what I'm trying to convey here is it's not just simply you know how to create those charts. You have to actually think and try to come up with the most appropriate type of chart to represent your data and the most appropriate type of chart and also the most appropriate format. For example, here an absolute number format is not fair because the total number in the hospitals is not fair. So a percentage would be more fair. So if we did the same thing we just did, but we actually use percentage, I highlighted them, then I pressed Alt F1, we'll get a totally different chart. Let's just pull it aside so we can compare the two. By the way, while you're moving this, if you press Alt at the same time, you move them to the borders of you align with the columns and rows, so it's not random motion. So here you can move smoothly, you can put it in any fraction, but if you press Alt while you're moving, you can align it with the borders of your columns, and it looks more neat this way. Anyway, so here, if we represent it as a percentage, and let's say display also add chart element and that data labels outside, you see that hospital 3 actually has much higher rate of infection compared to hospital A, hospital B, and hospital D. Okay. You can also sort, by the way. For example, here we can see that wound infection, generally overall in the picture, the highest form of infection is IV line infection, followed by wound infection, followed by infection. This data is purely hypothetical; it does not reflect real life. But I just wanted to, if you want your chart to look more neat, it would be more helpful to actually sort this in order. So you can sort this from the data, and it will be reflected on the chart, or you can sort it from the chart. Let's try sorting it from the data, for example. Simply highlight the data you want to sort, and then go to this usually exists in okay, the zoom icon isn't present. So just 1 second. Yeah, sort. Expand selection is on because you want to sort your data. So here your data is sorted. You can sort it in the opposite way, descending from the biggest to smallest. Group, sort. It's important to make sure that expand the selection is always selected, because if it's not, it will only sort this column. It will not sort all the related rows. So it will not also sort the catheter wound and IV line. So it will only sort the three numbers. So always make sure that expand selection is selected. Then sort. Okay, so see here, this is also a problem because it sorted the entire, even the total. You don't want that. You don't want to sort the total. Okay, there's another thing you can do here where you want the data. Advanced settings. It exists in Excel where you basically those columns should have to be, will be arranged in the reverse order of the data. Okay, so the same is done here. We can see that while dealing with absolute numbers, we showed the least amount of infections when we are dealing with percentages which are more reflective of reality, but are also subject to their biases because small numbers tend to show more extreme results. So this is another type of bias, but it's a less severe form of bias compared to this bias. We can still see here that hospital C has much higher rate of infection compared to the other hospitals, and specifically has way more catheter infections compared to wound infection and wound infection and IV line infection. Although in the other hospitals, catheter infection was not as high. So again, the take-home point is it's easy to discover, or on your own you can explore the different types of data, you can explore the different types of charts, but you have to always keep in mind that for any specific type of that data, there's usually an optimum way you can present that data. And usually you discover this stuff with trial and error and what makes sense. So do what makes sense to you, and then explore and make mistakes, and people will correct you. So this is basically almost everything. There's a lot of small things you can edit. There's a lot of small things you can express. Usually just hovering over something will tell you what it is. So this is the plot area. This is a specific bar for something. If you want to delete or anything, you can just press on it and delete and then see what it does. The same thing goes with every single option or formatting. You can just try the different options, try different combinations of options to see what happens. Okay. This basically concludes the first part, which is how to create charts, different charts. Now we want to also see doing the same thing using Google Doc.
Dr. Mohammed, we can do that in another session, but thank you so much. Just for the sake of time, we have one more topic, and I really appreciate this is great. Do you have any questions for Dr. Mohammed? If not, I'd like to thank you so much again, all the presenters, and we have the last topic. Please go ahead, the presenters, Dr. Malaz and Anna, if you are ready, we can go ahead with the item number 4. Thank you so much, Dr.
Hello,
Mohammed.
everybody. Hi, Dr. Nader.
Hello.
Yes, unfortunately, Dr. Anna has apologized because I think she's traveling.
That's all right.
Yes. Can you see my screen okay? And my voice as well?
Yes.
Okay, so today I'm going to be presenting about leadership in medicine. And as we know, doctors have always had a special role in society. We're not just treating patients, we're often seen as trusted voices in the community. People turn to us for guidance, and whether it's about health, ethics, or even social issues. That puts us in a unique position to make a difference beyond the clinic or hospital wall. So physicians become involved in leadership roles, sometimes through inspiration, sometimes because they were looking for a new challenge, but mostly due to chance rather than a deliberate choice, because they were the right person at the right place, or because the situation demanded that they step in and take this role. So many healthcare professionals become accidental leaders who are suddenly running projects, leading departments, and advocating for change. And just at that point, we realized that we need a whole new set of skills for this. So why should we, as doctors, step into leadership roles? Why not just focus on what we were trained to do, which is practice medicine? I think the answer lies in our values and our commitments. Our core purpose as physicians is patient care, and that includes not just treating individuals, but also educating future doctors and contributing to medical research. These responsibilities shape our profession and define why we do what we do. Our roles as doctors, it goes beyond the bedside. As doctors, we have the responsibility to speak up on health issues, whether it's something that is related to patient care or public health. And that naturally puts us in leadership positions. These factors are ingrained in us from the moment we enter medical school, and they continue to shape our career. So if healthcare policies and decisions impact our patients, then it's our responsibility to make sure our voices are heard in those discussions. So let's imagine that you, as a healthcare professional, are working in an underserved area where access to healthcare is limited. You notice that many of your patients suffer from preventable diseases like malaria, cholera, TB, and malnutrition, which are further exacerbated by poor living conditions or limited access to food and lack of access to essential treatment. At that moment, you start realizing that the issue goes beyond individual health, and it's more about addressing those systemic barriers. So you decide to speak up for change, perhaps by advocating for a mobile clinic to visit remote areas, or by lobbying for increased funding for the community. So it's more about ensuring that the future of healthcare aligns with the very principles that brought us into medicine in the first place. So now, before we dive deeper into the topic of leadership, let's take a moment to explore what leadership really is. A lot of people confuse leadership with charisma or management, but they're not the same actually. Management is great for keeping things running smoothly, handling logistics, solving everyday problems, and maintaining performance. But leadership is all about vision. It's about inspiring others, adapting to change, and guiding people towards something better. And actually, in healthcare, change is constant, whether it's about new policies or unexpected ethical challenges. And good leaders don't just react to change, they shape it. They set a direction, bring people together, motivate them to work towards a shared goal. For us as doctors, this kind of leadership is essential. It helps us navigate the evolving world of medicine. So here's the question. How do we empower physicians to lead change in healthcare? While health professionals do recognize that stepping into leadership roles is not only a need, but also a void and a gap in our field, many of us don't feel prepared for the challenges that come with it. And with the modern healthcare landscape that is quite sophisticated, and at that point, being an effective leader requires some skills that were not traditionally taught during medical school. So medical school teaches us how to diagnose disease, not how to lead teams, negotiate budgets, or navigate policy decisions. We want to develop leadership and management skills that we can apply in different settings, whether in our practice, in our communities, professional organizations, or in shaping public policy. That's a big question, and it's a natural extension of the medical profession itself. So what kind of support do doctors need to grow in these non-clinical areas? How can they develop leadership skills in order to be able to handle the challenges in today's healthcare landscape? I'm going to try to go over some of the proposed suggestions. Now let's talk about building a supportive organizational culture, because it's very important. When physicians feel valued, respected, and heard, they're much more likely to step up and take on leadership roles. So, how do we create this kind of culture? First, we need to establish clear pathways for leadership. This means creating leadership development programs, mentorship opportunities, and clear roles for physicians. For example, imagine a hospital setting up a physicians leadership academy, a program where doctors can get training in essential leadership skills like communication, conflict resolution, and change management. And this will definitely make them more confident when they step into leadership positions. Another important thing is that we need to recognize and reward physician leaders. When a physician leads a successful initiative, whether it's improving patient satisfaction or implementing new clinical practice, it's important to acknowledge that. Public recognition, awards, or even incorporating leadership activities into performance evaluations can go a long way. So, for example, a clinic can highlight a physician's efforts in a monthly newsletter or give them a special award during annual events. And finally, we need to promote a culture of open communication and shared decision-making. Doctors should feel comfortable voicing their opinions and contributing ideas. This can be done through regular town hall meetings or online forums where doctors can share their insights. When everyone feels like they have a voice, it makes it easier to come together and drive positive change. Now let's talk about why time and resources matter. Basically, we know that physicians and doctors in general, they're already juggling a lot of things, be it patient care, administrative tasks, continuing education, and on top of that, their own personal life. If we want physicians to lead change effectively, we need to make sure that they have the time and resources to do so. So how can we do that? How can we make that happen? First, we need to allocate protected time for leadership activities. This means setting aside specific periods in a physician's schedule or leadership roles, whether that's attending meetings, developing projects, or mentoring colleagues. For example, a hospital might allow physicians to dedicate half a day per week for leadership duties. This ensures that they're not overwhelmed and can truly focus on leadership activities. Also, financial support is key. If we want physicians to take the lead on quality improvement projects, research, or implementing new technologies, we need to give them the funding they need to make these initiatives happen. This could come in the form of grants, departmental budgets that allow these projects to take off. And lastly, we need to assign administrative and logistical support. Offering administrative support like helping out with data collection or scheduling meetings, it can free them up to focus on leadership. So another important aspect is technology, and technology is essential in today's healthcare, and physicians need to be comfortable using it to improve patient care and to make the workflow smooth and efficient for them. Basically, giving doctors access to latest technology from electronic health records to telehealth platforms to make their job easier and help them provide better care. It would also be helpful if they were offered hands-on training on recent advancements. And finally, we should encourage them to explore and experiment with new technologies. So basically, we want to create an environment where they feel comfortable trying out new tools, testing out new ideas, and sharing their experiences with each other. So another important point that I would like to address today is physicians' burnout. This is a real challenge that can impact both leadership and clinical practice. If physicians are burned out, it becomes harder for them to take on leadership activities. So it's crucial for organizations to focus on physician well-being to create an environment where they can thrive and lead effectively. The organizational environment and ethics of the workplace can influence burnout rates. Understanding and respect among leadership and colleagues can reduce burnout rates and increases workplace satisfaction. First, we need to promote work-life balance. It's essential to encourage healthy work habits, offer flexible schedules, and ensure that physicians have the time to recharge and to prevent burnout, basically. Also, providing mental health resources like counseling services and peer support groups can make a major difference in helping physicians manage the emotional toll. And lastly, let's create a supportive and inclusive work environment. When we foster a culture of respect, teamwork, and appreciation, it enhances physicians' well-being and make them more motivated to lead and innovate. Another key aspect is the power of mentorship and peer support. As physicians step into leadership roles, it's important to have guidance, encouragement, and inspiration from people who have already been through this journey. One way to foster this is by creating opportunities for experienced physician leaders to mentor those who are just starting out in leadership. Having someone who can offer advice, share experiences is invaluable. It's also helpful to build a sense of community among doctors. So, connecting with peers in similar roles allows them to share experiences, discuss challenges, and learn from each other. These relationships can be a great source of support. Finally, it's important to encourage doctors to actively seek out mentors and role models, whether formally or informally. Having someone to look up to can help you. Like, it can guide your leadership path and provide inspiration along the way. One of the most important things to remember is that healthcare is a team effort. No single person, no matter how skilled, can create meaningful change alone. It takes collaboration between physicians, nurses, administrators, and other healthcare professionals to make a real impact. To make this happen, we need to bring together teams from different backgrounds: doctors, nurses, pharmacists, and hospital administrators, so they can work towards a common goal. When different perspectives come together, we get better solutions. For example, if a hospital wants to improve medication safety, it makes sense to have a team that includes not just physicians, but also pharmacists, nurses, who can see the process from a totally different aspect. Beyond that, building strong working relationship is key. Creating opportunities for team building, whether through workshops, retreats, or even casual gatherings, it helps strengthen communication and trust and making collaboration more effective. And of course, none of that works without open communication. So, what type of qualities define a good leader? I think one of the most important qualities is that they promote opportunities for others. In addition to seeking opportunities for your own development, also look to create learning opportunities for others. Making opportunities for others shows your interest in seeing the members of your team grow, gain skills, and apply their abilities in the workplace. Another important thing is to prioritize communication. Good leaders know how to communicate effectively with the members of their team. Communication involves your ability to express ideas and feelings clearly so that those around you can understand your goals and perspectives. It also includes your ability to understand the needs, objectives, and attitudes of those around you. For example, if you are a senior physician, your role may include coordinating with your facility's administrative team. Communicating well across departments ensures that all members work together towards a common goal. Another point is that good leaders lead by example. And Leading by example means embodying the qualities that you want your team members to emulate. It involves demonstrating good values and habits like ethical practice, integrity, and communication. Showing your members your expectations by actively applying them during workday can encourage them to adopt good workplace habits. Team members also appreciate your ability to make the same and to meet the same expectations that you set for them. Leading by example can also help you develop strong workplace relationships with the members of your team. So ethical practice is essential in healthcare. Good medical professionals uphold high personal and professional standards of conduct. They are honest and trustworthy. They act with integrity, maintain professional boundaries, and do not let their personal interests affect their professional judgment or actions. Meeting a high ethical standard ensures that you meet the medical needs of your patients, protecting their health, the reputation of your facility, and your professional abilities. Also, another point that I would like to emphasize is active listening. It's often said that people don't leave their jobs, they leave their managers. The number one complaint people and employees in general have about their bosses is that they do not listen. And in today's world where technology and emails dominate, it's very important. So active listening does not only help you gather pertinent information, it also helps you to build relationships by showing your team that they matter. The simple act of listening demonstrates to your team members that their insights are valuable, their concerns are valid, and their feelings are important to you. By practicing active listening, you are not just respecting your team, you are transforming your leadership style into one in which ideas are shared freely and different perspectives are respected. And finally, they lead with empathy. The ability to demonstrate empathy and compassion is essential in healthcare. In my opinion, being empathetic and compassionate is one of the most important qualities in a leader. When leaders show empathy towards their team members, they create a sense of psychological safety that encourages open communication and collaboration. This, in turn, leads to higher levels of trust and engagement within the organization. Traditional leadership models often emphasize rigidity and strictness. In fact, at the end of the day, we're all humans, and sometimes our personal circumstances can influence our work performance. So a truly effective leader recognizes this and approaches such situations with understanding rather than harshness. Instead of immediately reprimanding a team member for their declining performance, I think it will be more mindful to try to understand the reasons behind the decline. So maybe they would have family issues or external pressures that are affecting their work, factors that are not immediately visible. And in the long run, this approach can strengthen both the individual well-being and the team performance in general. Thank you everyone for listening. Now, before I wrap up, I would like to open the floor for the audience to come through with their views on which qualities they deem important in leaders and maybe share any personal experiences. Also, Dr. Nader, if there is any point that you would like to emphasize more, we would love to hear that.
Thank you so much, Dr. Malaz, for great presentation. No, I think you covered all aspects, but thank you so much.
Thank you, Dr. Nader.
Any questions for Dr. Malaz or any of the other presenters?
Thank you, Dr. Malaz, for the great presentation. I think the most important quality is being an active listener, empathy, and recognizing burnout signs. Because, like you said, it is a very terrible thing to go through, and I think most people don't really realize that. Thank you again.
Thank you so much.
Thank you, Dr.
Go ahead, Dr. Malaz.
Yes, Dr. Nader. I have no addition.
Okay, I'd like to thank you
Thank you.
again and thank all the presenters for all the topics. And before we go to the update, I'd like to share with you that we have about 23 of our fellows match this year. So this is a list of them. Most of them were from senior group. So, and I think a few of them joined the meeting today. So if you'd like to comment, Dr. Lema and Dr. Namarik, I think you are still there. Please jump and give us some of your feedback or experience about the whole process and the program. Go ahead.
Oh, hello everyone. Just got here. Sorry about that. I was just a little bit out of my screen. So I haven't heard you. So if you give me some tips, I'll go ahead.
So if you want to share your experience, and first of all, I'd like to congratulate you and the rest of the fellows who matched this year. And for those who applied and had interviews, we wish you all the best. Just keep trying and good luck next time. Thank you. Go ahead.
Okay, thanks so much, Dr. Nadir. Yes, yeah, it's you know it's a challenging time for most of us, but I'm grateful and be lucky to match this cycle in internal medicine, and likely I'm not going out of my state. I'm staying in my state here in Washington, so that's good for me. But I had two unsuccessful seasons in 2023 and 2024. So I'm matched in my third cycle actually. So I've been having a lot of challenges all the way through, as most of the applicants know and face. So my main take on from my journey is just what I usually do and was trying to do is just to try to see what I can improve for the next cycle and work on my CV. That's been what I've been doing. So when I applied the first time, I was not having step 3, no clinical experience. So on last year, I decided to take step 3 and have some clinical experience, still not successful. And this year, more clinical experience and research experience. And I got lucky and much. So the only thing we can do is we have to focus which area of our CV that we can improve. There are some areas we cannot we cannot change. Our year of graduation, we cannot change that. Of course, we cannot change that, but if we stay, persistent, resilient, and our day is going to be coming possibly next year as well. So I encourage all of the applicants to stay focused and be resilient and work on that. And network and connection is also a critical point for me. I have been not active on LinkedIn for the last 2 cycles, but this cycle I've been like getting more information. And just to give you a tip, one of the program directors from East Coast just posted about the new programs. That was late January, I think. I don't remember the time frame, but I saw his post and have applied to some of the programs I'm interested in, and I've got like 2 interviews from that post. So we have to just try to get more connections and stay focused and work on that. And I believe everybody's time is gonna come pretty soon. And thank you.
Thank you once again. Congratulations. Anyone else in the group? I'm not sure if there is another fellow who matched. If yes, please go ahead and interrupt me or jump and tell us your story or your tips or advice.
If there's no anyone, I just want to add some more tips. I forgot to mention. So about your graduation, and I was one of the very old graduates. In my graduation year was 2009. So if those of you who are just like thinking that your graduation is a big headache, you can still match next cycle if you try to work on your CV and build some clinical experience and research experience as well. So I just want to add this. Thank you so much.
Thank you so much once again. And as you mentioned, there are red flags in the application, but you can overcome these red flags or things that you cannot change, but you can improve on other aspects. So the goal of the programs, they want you to start working. They don't want you to spend time during the residency learning the basics that you're supposed to have, the skills that you already applied in the past, and the system, the US health system. So if you have the clinical experience in the US, that will remove the headache from their head and trust you from day one. They're gonna focus on training you for the board exam and taking care of patients and so on. So if you show them that you have the experience, you are a responsible person, you have leadership, as mentioned in this meeting, and you are team member, team leader, and you have some publication at least, the research part and so on, it will help you. Did he ask you about the fellowship?
I couldn't catch that.
Did they ask you about our program during the interviews? Did any of the program?
Yeah. All of my interviews mentioned my participation in the clinical research fellowship, and I think it helped me a lot through my interview, and even to get the interview as well. So yeah, almost all of my interviews have mentioned about my experience in this research program.
I'm very glad to hear that. Thank you once again for sharing. And if there are no more fellows who match, I'd like to thank you so much for sharing your experience with us. And I wish you all the best. Keep us posted and let us know how things are going.
I will do that. Thanks so much, everyone. And if there's any, information or anything you would like to ask me, you can reach out to me anytime, and I will be happy to help and share my experience.
Sounds good. With that, I'd like to end the meeting. And if you have any questions, any comments, please reach out, send me an email, send me a text or call. We'll be happy to help you guys, and we'll see you next week. Assalamu alaikum.
Thank you, Dr. Nader.
Assalamu alaikum.